from Sarasota Memorial and the Deb Kavanaugh Multimedia Studio, this is HealthCast, a healthy dose of information from experts you can trust.
Hi everybody, welcome to HealthCast. I'm Allison Gottermeyer. Thank you so much for joining us today as we talk about venous thromboembolic disease and its treatment. Our guest today is Dr. Scott Perrin. He's a vascular and interventional radiologist. Dr. Perrin, thank you so much for being with us.
That's great to be here.
I'm only going to attempt to say this properly one more time. Venous thromboembolic disease. Now I can call it VTE. What exactly is it?
Well, it's really kind of an umbrella medical term for two disease processes. Basically, blood clots in the leg, which we're all familiar with, and they can break off and travel through the heart into the lungs and obstruct the arteries that supply blood to the lungs. So DVT and PE, or pulmonary embolism, are the two kind of medical conditions that are under the venous thromboembolic disease umbrella. And really, when we talk about venous thromboembolic disease, it's important to understand the context of what is thrombosis. Thrombosis is when blood clots form in blood vessels. And we all are familiar with heart attacks and strokes. And venous thromboembolic disease is kind of in that same category. It's thrombosis of a vessel that can cause injury and unfortunately death. It's the third most common cause of death after heart attack and stroke under the cardiovascular umbrella, and it's really kind of overall underappreciated as a public health entity. So, today I really hope to bring awareness to the disease process and, just try to shed light on what can be expected if, God forbid, either us or one of our family members is stricken with the disease.
Yeah, so we'll definitely go through and break some of that down.
Mm-hmm.
First of all, how common is VTE?
It's a very common disease process, unfortunately. It's the most common cause of preventable death in hospitalized patients. It's, like I mentioned, under the umbrella of cardiovascular disease, which is the number one killer in the United States. It's the third most common cause of death from cardiovascular disease after heart attack and stroke. So it really is just a public health crisis. One of the things that's really important to mention is, as a public health disease process, it's not very well known about. We all know, again, about heart attack and stroke, and those things even have lay terms, whereas venous thromboembolic disease kind of is in the shadows in a sense. So hopefully we can shed some light today about it.
Let's start with, you mentioned death, of course, which is a huge concern.
Yeah.
But why is VTE such a concern if left diagnosed, other than the obvious?
Yeah, it's a really important cause of mortality, like we've already discussed, but it also causes significant morbidity in the sense that if you are stricken with VTE, either a blood clot in the leg or blood clot in the lungs, we can kind of unpack those two entities. So obviously, when you have a blood clot in the leg, you can develop leg swelling, pain, immobility, and that can be the acute symptoms. Over time, the risk is that the blood clot could break off and go into the lungs and cause really a lack of blood flow to the lungs, which causes chest pain, shortness of breath. And then long-term or chronically, you can have it where you have a chronically swollen leg, you can have venous stasis ulcers, and in the lungs, you can have pulmonary hypertension, which can cause significant long-term disability.
So are there common risk factors for VTE?
Absolutely. I want to go over those. Really, we talk about three separate categories for the risk factors. Vascular injury, lack of blood flow in the veins, and hypercoagulability. So we can unpack those, in order. So for vascular injury, people that undergo surgery, people that have chronic inflammatory conditions, for venous stasis, people that have prolonged immobility, let's say if you went on a long car ride or a plane flight. And then lastly, hypercoagulability, including pregnancy, cancer, underlying diseases that cause the blood to be thickened. So there's a whole host of diseases from that. But in general, those are the kind of the risk factors for this disease process.
So can VTE be prevented in those kind of high-risk populations?
Yeah, that's a good question, and this is really gets to the heart of it in the sense that when we have this type of disease process, prevention, an ounce of prevention is worth a pound of cure. So in that sense, knowing about your risk factors, being able to prevent it in the sense like if you're going on a long trip, wearing appropriate stockings like compression stockings. Even taking like a baby aspirin, or if you had surgery or hospitalized, you could have a low-dose blood thinner administered. In fact, that's a very common practice in the hospital now that we have some understanding about the risks that people have, especially when they're in the hospital.
So are there any specific symptoms that people should be on the lookout for, especially if they're in one of those high-risk populations that's saying, I think I'm having a problem and I need to talk to my doctor?
Yeah, that's a really good question. With heart attack and stroke, the symptoms are pretty well known in the general population. A heart attack being like crushing chest pain, and stroke having like facial weakness. It's very easy sometimes to, even for a lay person, to know somebody's having one of those disease process. With VTE, it can be more heterogeneous and difficult to know. Obviously with a blood clot in the leg, you can have a swollen leg. That's very easy to understand, especially if it's one side. For pulmonary embolism, it can be a little bit more difficult. You can be short of breath, or you may not have shortness of breath. You can have chest pain or not have chest pain. So it can be a little bit more difficult to diagnose. The important thing is to notice that if you had something where you had a swollen leg or you had shortness of breath, those are the most common symptoms. So a lot of times people just feel unwell. They'll come to the hospital and say, I just don't feel like myself. And then, it'll be more further investigated. But in general, it's a little bit harder to diagnose.
How is it actually diagnosed once maybe a physician recognizes there's a problem?
Yeah, good question. So once the patient presents with some sort of symptom, there's basically two modalities that we use to diagnose VTE. The first is ultrasound. So we can do an ultrasound of the leg and look to see if there's any blood clots in the veins. And then secondly, we can do a CT scan of the chest to look for blood clots in the pulmonary arteries. There's also additionally some lab tests that can be done to look for heart strain or just in general looking to see if the patient's at risk for DVT and PE. But it is, again, a little bit harder to diagnose than a heart attack and stroke.
What does the prognosis look like for someone with VTE?
Well, if it's caught early, the prognosis is very good. It's something where we have the mainstay of therapy really is systemic blood thinners. Like I talked about before, prophylactically, blood thinners are given in high-risk populations, but when someone develops VTE, systemic anticoagulation becomes the mainstay of therapy.
What does treatment look like?
Yeah, so there's a spectrum of disease for VTE, and we talked a little bit about it. Sometimes the symptoms are mild and can just be treated with anticoagulation, but sometimes really the burden of the blood clots in the vessels can determine whether something more invasive becomes an option. That's kind of where my specialty comes in. VTE treatment is a multi-specialty approach, especially given the fact that there's so many factors that go into it. So for example, if you have an underlying hypercoagulable disorder, you'd need to see a hematologist, okay? If you have blood clots that are obstructing flow in the lungs, the pulmonary embolism, and you're in the hospital, you're gonna see a pulmonologist. You may see a interventional radiologist like myself in order to decide whether or not those need to be extracted, using catheter-directed therapy. So in that sense, again, there's a spectrum of the disease and how severe it is. And then depending on what's needed, you may see a host of different physicians over time.
How does that work in a major health system like Sarasota Memorial with all those different modalities kind of collaborating together?
Yeah, that's really, I'm glad you brought that up. So at Sarasota Memorial Hospital, we really are a tertiary care center, as you know, for the community. And so we have to be able to provide that responsiveness and that multidisciplinary approach. To that end, we're developing a pulmonary embolism response team for Sarasota Memorial Hospital. And that really is, like we talked about, a multimodality, multi-specialty team of physicians, pharmacists, nurses, that can respond to this really emergent situation, similar as if you would have a response team for heart attack and stroke. So we're on the forefront of treatment for this disease process and recognizing it as a true medical emergency.
Can you talk more specifically? You mentioned catheter-directed therapy, which is where you're involved. So what exactly does that look like?
Well, I'm really excited about this part of the disease process in the sense that just over the past few years, we've seen a huge change in what we can offer as far as catheter-directed therapy. Additionally, there was no catheter-directed therapy offered, even 10, 15 years ago. And then slowly we decided that by putting catheters in and administering medication through the catheter, we could help dissolve the blood clots in the lungs more quickly or in the leg more quickly to relieve the obstruction. Recently, we have the ability to go in and actually remove the blood clot mechanically, either with aspiration or to try to break it up. And that is very exciting because we've seen patients similar to what we've seen with stroke, where we can go in and remove the blood clot out of the brain. This is similar. We go in with a device and we're able to essentially remove the blood clot, remove the obstruction out of the pulmonary arteries, and there is a rapid improvement in the patient's condition. So that's where we're headed with this type of therapy, in the sense that we can rapidly remove the obstruction and decrease not only the morbidity of the disease process, but also the mortality.
Are there any contraindications for that treatment?
Talking about contraindications for VTE treatment, one of like I mentioned, the mainstay of treatment is anticoagulation. And the biggest contraindication to that, to anticoagulation, is bleeding. So unfortunately, some people have a propensity for both thrombosis or blood clots and bleeding. And that can make treatment of this disease process very difficult. One of the things that we can offer is placement of an inferior vena cava filter to limit the possibility of a large blood clot breaking off from the leg and traveling into the lungs. So that's one thing that we can offer kind of as a consolation in someone who has bleeding but can't be anticoagulated. But in general, there's no absolute contraindication to going in and taking out the blood clots, fortunately. So any patient can have that performed if needed in an emergency situation.
How important is it? I mean, it seems obvious, but how important is it to just have more treatment options for a disease like VTE?
Absolutely. The first step is just raising awareness. It is something that's not known about. One of the things I want to mention is we've seen the mortality rates of heart attack and stroke slowly decrease over the past 20 years because of that awareness, because of the fact that people have developed these streamlined treatment approaches to those disease processes. And really, venous thromboembolic disease has been left in the dust in that sense. It's under-recognized, under-diagnosed, and undertreated in a large part, especially with the catheter-directed therapy. So we hope to remedy that at Sarasota Memorial Hospital.
How effective is treatment for this patient population?
It is very effective, especially when there's a large blood clot and it can be removed. Anticoagulation is effective, but again, it really does depend on the burden of disease and what patients need the catheter-directed therapy versus just systemic anticoagulation.
Is there a big difference in how the treatment works for DVT versus PE?
Yeah, it's a similar approach. Obviously, pulmonary embolism can be more life-threatening in the short term because it's obstructing flow of blood into the lungs. So the deoxygenated blood that's coming from the venous system is obstructed, and that really puts a strain on the heart It puts a strain on the ability of the blood to pass through the lungs and become oxygenated. And when that happens, it can be acutely, problematic in the sense that you could die of that. For DVT alone, just the blood clots in the legs, one of the things that could happen is you can have a complete obstruction of the blood flow, like a phlegmasia, if you will, but that's very uncommon. So in the short term, pulmonary embolism is much more dangerous and that's why I mentioned the pulmonary embolism response team. But if we're able to identify DVT sooner and treat it, we can not only decrease the risk of pulmonary embolism, but also decrease the risk of long-term disability from the blood clot in the leg.
Especially for patients who have this catheter-directed treatment, what does follow-up look like for them?
Yeah, so a lot of times they're followed by the interventional radiologists in our clinic, vascular surgeons, pulmonologists, hematologists. There's a lot of doctors that are involved in the long-term care of these patients. And I'll mention the rate of recurrence in this disease process is relatively high. It's 10 to 20% in 5 years. So it is very important that this be treated as not only a short-term illness, but a long-term illness that needs to be followed very closely by a team of physicians.
Why is recurrence so common?
Well, a lot of times the underlying risk factors are hard to mitigate. So if you have, let's say, cancer, or if you have something that's, a terminal problem, or if you have an underlying hypercoagulable state that's genetic, that can be difficult and sometimes impossible to treat,
Is there anything else you want to add? Because I know we've touched on a lot today, but being that this is a disease that is not spoken about enough, as you mentioned, is there anything else you want to add to this patient population or to the community to be on the lookout for?
Yeah, that's a good question. So there's two things I want to say. One is that, at some point we're all going to be affected by this disease process. Personally, my grandfather died of VTE after a hip surgery. And that could have been prevented if he had, taken his Coumadin, or, back in the day, that's what they gave. But so that's one thing I'll say, is that we're all going to be touched by this one day. It's just a very common disease process. So it really behooves us as a family, if you will, in Sarasota, to educate ourselves about this disease process. There's a website, Stop the Clot Alliance, that I could recommend people look at. And I think that there's a World Thrombosis Prevention Day in October. So it's something that we really do need to take into consideration, similar to as we look at other disease processes such as like heart attack and stroke, like we mentioned, and really kind of understand that this is something that really we need to bring to light and talk about and understand as a disease process because of the high morbidity and mortality that it causes in our community.
Anything else?
No, thank you so much for having me. I really appreciate it.
Dr. Perrin, thank you so much for joining us and answering all these questions. As always, we encourage everyone in our community to visit smh.com to get the latest from Sarasota Memorial. Have a great day.